the best advertisement I've always come to find out is word of mouth. So once you get that word of mouth advertisement as they're actually doing something for us, it's really starting to really take off. And that is exactly what we want.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
Joining us now is JD Buchert, Director of Workforce Safety at Parkland Health in Dallas, Texas. You know, Chris, when I think of the term workplace violence, I usually think about bullying or some other form of violence between coworkers.
Yeah.
But that's actually not what we're talking about today. And we're going to be discussing a different kind of workplace violence. And honestly, there is no better person to educate us on this topic today than JD.
Absolutely. And not only is JD doing amazing things, but you're going to hear about the great things coming out of the Lone Star State. And I can't wait for people to have a better understanding about workplace violence, but also about the training opportunities that are out there.
Absolutely. So don't go anywhere. We'll be right back with JD Buchert.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is JD Buchert, Director of Workforce Safety at Parkland Health in Dallas, Texas. And JD, thank you so much for joining us today.
It's such a pleasure to be here. Thank you so very much for allowing it.
It is an honor to have you joining us in the studio today. I know that you're an expert on the topic of workplace violence, and you've spoken on this topic before. And so to be able to have you join us and to share your expertise with our audience today is really a pleasure. So to start things off, why don't you just tell everyone a little bit about yourself?
Oh my gosh. I'm very fortunate. I've been a nurse for about 38 years now, and I've retired combat nurse out of the U.S. Army, and had such many wonderful experiences while I was in the military. When I came to the only civilian hospital I've ever worked at, Parkland Hospital, after my retirement, I was in the OR. And from the OR, once I'd finished my third master's, they told me that, hey, you need to grow. And so they
like
said,
3 masters isn't enough?
Well, I just finished my 4th.
Oh my gosh, congratulations.
But thank you. So they said, well, have you thought about quality and safety? And I was like, well, that sounds very interesting. So I went that route in the perioperative arena. And then from there, found out about the workplace violence and how it is affecting healthcare. And from that, I became a nurse's nurse at that point and really started to advocate for our workforce here and across the state and actually in the nation too, just to make sure that there are eyes on workplace violence because it's so predominant in healthcare.
I am just kind of in awe already. I'm just like, oh, I can't wait to just have this conversation. But I need to put the brakes on it just for a second, because I know you have a lot of great things to share with us today, but I can't let this moment go by because this episode is airing on Veterans Day. And what a better guest to have than a military veteran in our studio with us. So let me say thank you. Thank you for your service and for your sacrifice. I am very grateful that you committed your life to the military and to serve our country.
I'm tremendously honored, and thank you very much. It's probably one of the best things that I wear on my sleeve. The experience and the growth that I got from the military really helped create the type of person I really wanted to be. And I owe that to the military and, of course, my mother, too, because she is my number one hero.
Oh, bless the mamas.
Oh, bless mamas for sure. And I know that this is Veterans Day, and we want to say thank you to any of our veterans who are listening, and definitely to say thank you for your service. But any day is a good day to say thank you. And so thank you to anyone listening, to you, JD, but also Chris, to you. I realize that your husband is also a military veteran, but that makes you the spouse of a veteran, and your sacrifice is just as important and paramount for the success of his career. So thank you for your commitment and your sacrifice too, because I know it was a lot.
Well, thank you. I appreciate it. But it's also such an honor to serve the country, just like JD said, and it's brought us so many blessings. So yeah, what a life, right?
Right. Absolutely. So on this Veterans Day, as we are having our veteran with us in the studio, let's move on to our topic. We're talking about workplace violence. But JD, what exactly is it that we're talking about today?
Well, a lot of people just associate workplace violence with just the physical assault. And it's so much more than that. Right now, we're seeing about 81.6% of all healthcare workers have been victim to workplace violence. And when we're talking workplace violence, we're not only talking about the physical assault, but the verbal threats and the verbal assaults that come with it. But it also goes down to that racial slurs, the sexual innuendos, anything to that aspect. And it also includes destruction of property. And so when you start to look at this bigger picture of really how it's affecting our healthcare environment, it really does become a topic bigger than us, if you can understand. It's something that just continues to grow. And it really started to take predominance after the COVID epidemic. It had really kind of sunk its teeth into the global aspect of what healthcare really is, because it really changed and became to the point where now 3 nurses are assaulted every hour in the United States.
No way.
And so if we look at it, 60% of all workplace violence is happening in healthcare. So if we look at this big picture of all of the professions in the United States, 60% is taking place in healthcare. And
that's scary.
when we're looking at a career that is facing many shortages, is this one thing that we really want to put on that shelf and not really face down? Because everybody wants to come work in a safe environment. And when we work in a safe environment, we're going to be able to provide better care for our communities and our patients. And that's why I do what I do.
Well, so speaking of why you do what you do, in the environment, specifically in the operating room, one of the things, especially as an educator, that we teach our students and upcoming surgical technologists and nurses is that, we can't just walk away when a situation gets tense. That's called patient abandonment, right?
Very true. Yeah.
And so in those really critical moments, those situations get tense. And so you in your role, how do you facilitate safety in those ambulatory centers? And, can you talk a little bit more about your role specifically and how it pertains to healthcare workers and how can you facilitate safe environments in places where just the environment alone, I think, pertains to moments where it can get a little scary?
There's so many things that ambulatory surgical centers and hospitals themselves need to do to really make their environment safer. One thing that we're seeing is about 11% of all workplace violence is happening in that ambulatory surgical setting. However, if you look at it, within that 11%, you have like a 70% higher rate of harm scores in that setting too. So when we see the highest predominance of workplace violence happening in the emergency department, and a lot of times those emergency room trauma patients or patients are going up to the emergency surgery arena, we are starting to see where there's almost like a dissatisfaction of what they were expecting, that patient or the visitor that comes with that patient. So when they are through their procedure and then they're finding out that their pain is not taken care of or the outcome of that surgery is not what they thought it was going to be, they're coming back for revenge. And one thing that we're seeing in the hospital setting is they've done their risk assessment and they have established those safety protocols in that hospital setting. But a lot of times we're not seeing that in the ambulatory surgical setting. A lot of times they're not associated with hospitals. They may be privately owned. And they don't understand the importance of that safe environment because it's never really happened to them before. But in those ambulatory surgical settings, we've lost surgeons in Oklahoma and in Tennessee to gunshot violence. And it's just training that staff and making sure that we have all of those protocols in place. And that's kind of what I do is I help with establishing those, but I also really start to really focus on those events that can escalate up to a higher level of harm.
Yeah. Ignorance isn't necessarily bliss in that.
It is not in this. This is,
right, yeah.
Very true.
JD, will you tell our audience a little bit more about what you mean when we hear the words harm score?
Well, harm score, what we use here at Parkland is this matrix harm score, and it goes from 0 to 9. 9 being death, 0 just being a near miss, if we can say that. It's something that has potential. What we're seeing in workplace violence normally is a 3 or a 4. It could be a lower level harm score. It's just basically it's like I was in fear. I was in fear at that moment, but I was able to get myself into a safe environment. However, then you start to get those higher levels that are temporary harm or permanent harm, and then it goes up to how this harm is so permanent that I'm disabled now, or this harm it gets to those higher levels all the way up to death. And what we want to do is, if these if we're receiving these workplace violence incidents, we want to make sure that they're low, number one, because it's not something that is. I was out of the office for 3 days this week, Friday and Monday, Tuesday. And within those calendar days that I was at, we had 45 workplace violence events in our facility.
Oh my gosh.
In one facility.
Wow.
In our healthcare system.
In your system.
And so when I'm looking at those, we are looking at 1,400 a year plus. And the reason that this is becoming, we're seeing these numbers is because we really start to set that just culture environment where people are very comfortable in reporting these events and they understand the difference of really what workplace violence is. Because if we can catch it at the beginning, we can write that behavioral warning letter or that behavioral expectation letter to those patients or visitors so they know exactly what their expectations are when they come in as a patient. A lot of times people forget that.
Yeah. Well, I think it's interesting that you mentioned not just patients, but you also mentioned family members and visitors, because it's not always the patients. And having worked in med-surg and having worked on the floor, I have experienced some very unhappy and unpleasant family members. And so to be able to, I guess, go to my leadership and say, hey, I am uncomfortable. This person is being aggressive or something. And to know that your leadership takes it seriously and then will then follow through in order to protect you, but also to protect the environment and other patients and staff. That to me is really reassuring. With the incidents that you mentioned that happened in the 3 days that you were gone, were all of those incidences from patients or visitors towards staff, or were any of those also staff to staff? And do you track those as well?
We do track those, but I only focus on the patient or the visitor workplace violence against our workforce. And so if I do get those incidents where it's staff on staff, we know that sometimes our providers have a little bit of control issues, and that
No.
and then we address those through separate channels. And we do keep those statistics also, because one thing that we're allowing ourselves to do is set benchmarks, because we always want to make sure that we're bettering ourselves, right? We want to reduce this. We want to have that hindsight of 2020. It's like, what can we do to make our environment safer for our workforce? And so with that, I think that I always say knowledge is power. And with that knowledge, we're able to really start to focus on how we can make an environment safer.
I was just curious because I know that you said that now that you have created this environment where people feel more comfortable reporting, you're going to see reporting numbers go up. But with
Yes.
that trend, are you seeing just in general the workplace violence trends going down?
Well, we're seeing those levels of harm going down as we're seeing an increase in reporting. The great thing about our facility is that we just became a high reliability organization. And as we transitioned into that over a year ago, that's where we're really starting to implement our just culture. So with that, the reporting is increasing, but also the actions are increasing, because without having that reporting, we don't know what's happening. As we have 75 occupied properties within our healthcare system and 15,000 employees or workforce members, you really got to think about, all I see in front of me is what is reported on the screen or in those incident reports. So when we receive those incident reports, or we have a hotline, or we have an email and so forth, when we get that knowledge is actually when we can really start to have actions start to take place. The best advertisement, I've always come to find out, is word of mouth. So once you get that word of mouth advertisement as they're actually doing something for us, it's really starting to really take off. And that is exactly what we want.
So, JD, one of the things that you mentioned, and going back to knowledge is power, and one thing that we as nurses are also taught is understanding where someone else is coming from and understanding what might drive behavior, what might drive attitudes and actions. It certainly doesn't excuse violent behavior by any means, but it does help us understand why someone may do what they do. And that phrase is trauma-informed care. Can you talk a little bit about what trauma-informed care is?
Well, and that is one of the basis of how we really started to organize this. We integrated trauma-informed care once we realized the importance of it. And basically what it is, it's the approach that considers the patient's past and present life experiences. And it also aims to reduce the impact of the trauma that itself that may be taking place. Because we all know that sometimes it's those triggers that really make us act as what we are doing. I know sometimes my triggers may be somebody driving 40 miles an hour in the left-hand lane of the highway. And it really
Everybody knows that's for breaking the law. Come on.
It might set me off to say some words that I should not be saying.
Especially on 35.
Oh my gosh, yes. Oh.
But what it's based on is the idea that traumatic event can be terrifying and overwhelming, but it should also have a focus in restoring the sense of that safety and power and even that self-worth within that patient. And that's the guide that we're wanting to do. We don't want to punish them for maybe outbursts that may be associated with something that was just a trigger for them. But we want to make sure that we set expectations with them. And we can also give them resources to work through that trauma.
So how do you determine those triggers? What does that process look like?
Well, we have an interdisciplinary collaboration with a bunch of our professionals here at Parkland, and some of those are trauma-informed psychologists or trauma psychologists, and then we have psychiatry, and we have providers, and we have nursing and operations. The great thing about that is that we can really come down and try to pinpoint the best action that we can take to support not only making it a safer environment, but try to navigate to the best care that we can give to that one certain patient. Well, unfortunately, there are some times that we can't provide that, and the patients are just going to be what they want to be, and we've gone as far as terminating those patients. And in a safety net community hospital, it's very difficult to be able to figure that out, because of EMTALA, we're still going to provide that patient with the standardization of care. So we're going to stabilize that patient in our emergency department. But now we have protocols within our emergency department that will navigate that patient when they come in. So 2-man teams, we have a fast track process for them. We fast track their testing, everything that we need to do to make sure that our workforce is safe while still stabilizing them and giving them the best care we can.
Well, and I think you also, as healthcare providers, we all understand that if they're in our health system, they're not there because they're having a good day, right? And the patient, and so the patient is so focused on the problem at hand, whether it's a heart attack or a fracture or an injury, they're not exactly thinking about having that Southern hospitality or the manners. And I'm sure all of those things are taken into consideration. That the last thing they're thinking about is, being as polite as they can to the staff that's trying their best to take care of them.
And it comes down to what we also bring, because our words matter, our voice matters, our body language matters, and it really comes down to we got to hold ourselves accountable just as much as we want to hold the expectation levels for our patients there too. And there are times that we have to check ourselves too.
You know what? I think too, like Chris, what you just said, let's think about our perioperative patients, right? Our surgical patients. They have had to make arrangements to be off work, maybe a day, maybe a week, maybe 3 months, depending on what they're doing.
Yeah.
They're hungry because we don't let them eat. They're there. They're scared. They're afraid of what pain may follow after surgery, or they're already naked. In pain. They're naked. They might be cold. All of these things. Oh, and then the surgeon's delayed, or they're waiting, or, it's like, pick any number of variables, and then suddenly they're already not in maybe the greatest place possible because they're here to have surgery. Yes, we're going to take good care of them, but all of those variables play into how we might be responded to from the patients that we go see when we go talk to them in pre-op. And I know that all of that feeds into sometimes some snappy, irritable responses, especially when they've laid there all day hungry, and then you have to go tell them, yeah, we need to reschedule your surgery. And that we just did that actually 2 days ago at my facility. So yes, I know that it happens, and patients are rightfully upset when that happens. But even when a patient's upset, and even when family members are angry, mad, etc., there are still expectations, JD, that we have to set with our patients and with family for proper behavior and proper response. So how do you set those expectations with patients at the forefront so they understand how things are going to work in your facility?
We have it in multiple different arenas. One is we actually built it into our consent.
Oh, and that's a great idea.
We have signage throughout our facilities, what our expectations are when they come in. But it's not only for the patient, it's for the visitor also. But as I said, part of it's on us. So we have got to use clear communications. And that is, hey, this is what's happening right now. I want to make sure that you're part of this because it affects you. So if there's a trauma surgery that comes in, or if there's something that becomes more of a priority that we have to take care of for the safety of that patient, I want to make sure that you're aware of it as a patient also, that there is something going on. Please don't think that we're ignoring you or anything to that aspect, but just keep that patient in the loop. That's one place that we tend to fail a lot on, is that lack of communication, or somebody else is going to do it. And we don't take it upon ourselves to really make sure that we're communicating and we're advocating for that patient on one aspect or another too. And I think that becomes a very important thing, because that's going to be our biggest de-escalation tool also. As that patient starts to escalate because we haven't communicated with them, this gives us an opportunity to really get at the lay of the land. And if those events do start to escalate, we should have the tools in place to de-escalate them right away.
And that's a great segue, because I was about to ask you about that. You're reading my mind, JD. Yeah. So, we medical people, we're really good at the medical stuff, right? But we need to know what happens when maybe all of those consents and that signage and just things get in the way, and the patients and their family members don't behave accordingly. How do you train your staff to handle those situations and go through that de-escalation process? What do you all do?
We actually are very fortunate that we provide a de-escalation course here at our facility. It's called SAMA, but it stands for Centauri Alternative Managing Aggression. And so with that, it's like CPR. We do it once a year. You go through this training, and what it does is it teaches you step-by-step actions on how to approach an aggressive conversation. And then once you have those tools, you're able to de-escalate that patient or visitor or even other staff members or surgeons I was very fortunate. On my first day that I went through this class, in my 30-year marriage, I went home and I actually won an argument right away, and it didn't take longer. I didn't have to prove myself. It really gives you these tools.
I need this training.
I was going to say, don't teach my husband.
It gives you these tools to be able to navigate an angry conversation to a good point. But it also gives you these tools that if they do become more of a physical threat, that what steps you should take there too. And we're very fortunate and that we do have that training. There are other training de-escalations that you can get online and so forth. And I always say that investment is going to be just like all education, which I'm a huge advocate for, is anything that you can do to improve yourself or your environment is really going to be beneficial to yourself and to your environment. And so those are the things that we do it with CPR. I honestly, wholeheartedly feel that we should do it with de-escalation in today's society.
Absolutely. So, JD, one thing that we talked about when we talked prior to this recording was a new thing that Joint Commission is actually looking at when they are doing their surveys, and it is actually related to workplace violence. Can you share with everybody what it is Joint Commission is looking for?
There are actually 4 Joint Commission standards that really focus on workplace violence prevention. And these are requirements now, which is as of January 2022, I believe. What is EC 02.01.01? And it's the hospital manages safety and security risk. Basically what that means is this EP 17. It means that hospitals and ambulatory surgical centers, do they conduct annual worksite analysis related to workplace violence prevention programs? Do they have a workplace violence prevention program in place? And that is a requirement for hospitals, and it's becoming a requirement in the ambulatory surgical setting. In fact, Texas passed a law, Senate Bill 240, that requires a workplace violence prevention plan be in place for all healthcare arenas.
Wow, I love that.
And so we also passed a Senate Bill 840, which now makes violence against a healthcare worker a felony. Up until then, it was a jaywalking ticket. It was just a fine, a misdemeanor that would be, I think, a $50 ticket. Now it can have substantial fines and jail time also.
I know some people that would have put a 50 on the table at the nurse's station and been like,
yeah,
worth it, Yeah, absolutely. So way to go, Texas.
Yeah. So other things is we have EC 04.01.01 is the hospital collects information to monitor conditions of the environment. And 2 things fall underneath that for our Joint Commission standards. And one is that we establish processes of reviewing and investigating incidents with staff and patients and visitors when it comes to workplace violence. And the other one is that we investigate the safety and security incidents involving this same venue. With that, we are making sure that we are actually following through those high level and low level harm scores. We're making sure that we have action that we can take in case these events are taking place. The other standard is the HR 01.05.03, and that's the staff participate in ongoing education and training. At our facility, we have annual training every year that includes workplace violence prevention. And my big thing, knowledge is power. We give them all the knowledge that they need to know, and then that they can grow from there, because you're never going to have all of the knowledge that goes on place, but we can always continue to grow through our experience. The last thing is LD 03.01.01, and this puts a responsibility on the leaders of the organization, and that's for them to create and maintain a culture of safety throughout the hospital and healthcare system. And so these are 4 things that the Joint Commission is now looking at.
Wow. And so
That's
when they
a full circle moment.
Yeah.
It's very rare to see legislation that truly, holds all parties accountable. And that feels like it's what Joint Commission is doing, which is, it's nice to see. So
it's exciting. And
absolutely.
As right now, there's a federal legislation, it's called the SAVE Act. And the SAVE Act has 109 bipartisan sponsors. And I was just in Washington, D.C. in June to go out there and just press the flesh to try to get more and more sponsors that we can on this. And what that is it's what we're doing here in the state of Texas. It's creating a workplace violence prevention plan regulation for every healthcare facility in the United States. But it also gives focus on workplace violence prevention in healthcare across the United States. And with that, just like the airlines have, we are asking for that for our healthcare system too. There needs to be a standard and an expectation nationwide on this. So.
Absolutely. And that really just brings this conversation, puts a nice little bow on it and brings it to a close. But yeah. I really want to give you the mic one last time before we wrap this conversation up. Is there anything else that we didn't get to? Anything else that you want to share with our audience before we finish our conversation today?
Well, the one thing is I always say to anybody and everybody that will listen to me, and sadly I walk around with a soapbox all the time, is that I want them to be able to go to work and feel safe. And if you don't feel safe in your environment, don't hold it in. Share that with your leaders. Share that with your people. If you have a shared governance, speak to them about it. If you have a donuts with your CNO, we call it here Donuts with Donna. And once a month, our CNO will come out there and she will have an open table so anybody can bring anything up. Just have your voice heard. Just like I always say, go out and vote and register to vote because your voice needs to be heard. Just like that in our healthcare system, you are your own advocate as much as you're an advocate for our patients. Because when you're advocating for yourself, you're advocating for the workforce that you're with. And just have your voice heard. Create your own safety in your environment. If you don't feel safe in it, make sure that people know.
I couldn't ask for better advice. What a wonderful interview today, JD. Thank you so much for being here. We really appreciate it.
We've enjoyed it.
It was my greatest pleasure, and I thank you so much for the opportunity.
That was JD Buchert, Director of Workforce Safety at Parkland Health in Dallas, Texas. And Chris, all you have to do is turn on the news and you will see reports of violence. And there have been some really sad stories recently of people who have been injured or have lost their lives due to violence from patients or family members. And sometimes I think that because those of us in the OR work in a restricted environment, and we don't always see the family, right? And our patients are asleep, that we don't actually think about the reality and even the risk of violence that we could be exposed to in our hospital setting.
Yeah, absolutely. And the big joke is anesthesia always wins, right?
Right.
But I love that JD is working so hard, not just in his facility, but also nationally. And it's nice to see all of the things that Joint Commission has put into place too, because our patients are empowered, our staff is empowered, and there's training out there to teach us what to do when things go wrong.
Absolutely. And you're right. I agree. I am really happy to see that Joint Commission is prioritizing it so that it is something that our facilities have to do and are working on, but then also to see JD's advocacy for not only his facility, but like you said, being the nurse's nurse and advocating for us. I think that is going to go a long way to making our work environment safer. And that's going to do it for today's interview. As we bring this episode to a close, once again, let me say thank you to all of the military veterans who are listening in our audience today. Thank you for your service and for your sacrifice. And on behalf of Chris, myself, and our whole team, thanks for listening to First Case.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.